Good evening, everybody. Welcome to this Retina UK webinar. I'm just going to give us a few moments just for other people to join. So if you just bear with us for a little while, we'll let people trickle in for a few seconds. If you have just joined us, welcome to this Retina UK webinar. We're just giving people a few moments to join, but I will get going very, very shortly. Okay, good evening. Welcome to the Retina UK Ask the Experts webinar. My name is Kate Arkle. I'm the Research Development Manager at Retina UK. And in today's Ask the Expert session, we're really pleased to be joined by Professor Marcela Votruba. Marcela is a Professor of Ophthalmology at Cardiff University and a consultant ophthalmologist at University Hospital Wales. She's an active researcher who has a particular interest in retinal disorders and optic nerve disorders. And she'll be answering your questions this evening. My colleague, Lauren Osborne-Lewis, is also here in the background. She is here just to help manage questions and the technical side of things. We've received quite a few questions in advance, so we'll be working our way through those to start with. If you haven't already asked your question, you can type it in the Q&A box at the bottom of your screen. Please use the Q&A box rather than a chat function. And then Lauren and I will monitor those and we will ask the questions on your behalf. We'll try to get through as many questions as we can, but any questions we're not able to get to, we will endeavour to get in touch with you after this evening. Okay, Marcela. Thank you so much for joining us.
Pleasure.
So we've had some really good questions. And one of the first ones I'm going to ask you, I think, is common to a lot of members of our community. So this is from somebody who says, I've had genetic testing done, and all I know is that my form of RP isn't one of the 80 plus that they have so far identified. Do you think it's likely that the root cause will be identified ever in my case? And if so, can you estimate a time frame? So this is somebody who's obviously had a genetic test and then not actually been able to get a genetic diagnosis.
Thank you. It is a common question and it is a common problem, and it is unfortunately very frustrating for both the patient, the clinicians and everyone concerned, because we do try to be realistic about why we're doing the testing, but it's at least important to get a result. So first I'll say that between 50 to 70% of people will get a positive gene diagnosis, have current standards of testing with the current technologies and so on, which means that a sizable number of people are still not able to identify a specific gene for themselves in that testing. I always say to people in part of the counselling about why we're doing the test is that this is information that's going to be an investment for the future. And that it's your information and it'll be valuable, but we can't necessarily do anything with it straight away. But I also tell people that maybe 7 out of 10 people will get a result and 3 out of 10 might not get the name of a gene. But I always emphasize that doesn't mean that it's not genetic. And that doesn't mean that we won't ever find the name of the gene. It just means that we won't have looked now for that gene because it's not on the panels or it's not part of the data that's known about genes that can cause retinitis pigmentosa, so it's not screened for through the analysis. It's quite likely that the actual gene that has gone wrong in you, if you like, is there within the data that's held about you from this test. But because the knowledge about that gene isn't yet developed, we don't know that it causes RP. It may never have been reported before. So your data could be reanalyzed. So this is one option. And I actually faced that situation with a lot of people. I've been wondering whether we should be thinking about this as capacity in genetics increases. Yeah. Some people will have had tests 3-5 years ago, and now we might be able to find that answer if we were to reanalyze some of the data. I always say to people, another option is to play the long game and to reanalyze or to retest in the future, because the tests get better, faster, more reliable, and they cover more and more genes. And the data behind it, the so-called bioinformatics, gets better and better. So I think the short answer to your question is I do think you will eventually know which gene has gone wrong. I feel that there could be the very tiny remote possibility that your condition has been called retinitis pigmentosa but is not in fact genetic, but that's very unlikely, particularly if you have a family history. But even if you don't, the clinicians will have done all the clinical testing, so they would be really sure that this is highly likely to be genetic. Unfortunately, until that time, it's going to be difficult to counsel you about your likelihood of passing this on, whether it could be passed to 50-50 of your children, 50%, or whether it's more likely that it's got more likelihood of a recessive condition, which is unlikely, so you wouldn't really pass it on, or whether it's sex linked. But again, you may know if there's a family history already, what that kind of picture in your family might look like. But it's frustrating because until you have the name of that gene, you can't really even know where you fit in. And patients are really keen for that information. They're hungry to know what is going on in research, what's my gene looking like, where are there any trials for that gene, how can I get involved, who should I speak to, have I got anything in common with these people or those people. But I do think you should take the long view. I think it will happen. There's a very high chance that it will. How long? That's a difficult question because it's always wrong, the answer. The crystal ball just fails at this point. But I think we are now in a position where more and more testing is being done through what's called whole genome screening, where the whole of your DNA is sequenced, but only the parts we know cause the RP are analysed. So that means that it could be reanalyzed and your clinician could advise you whether that's practical at the moment or not. And if it hasn't been tested in that way, if it was tested a long time ago, it might even be feasible to retest. So you need to discuss it really with the clinician. If it was a recent test, then I would wait and look out for developments really.
Yeah, and I think you've summed it up really well. So many people just want to know. But I think, is it true that when you have a whole genome sequencing, when you consent now for a modern sort of whole genome sequence test, I think there is an option to say that you're happy for your sample to be used by researchers. And actually, is that correct?
Yes, yes,
and I think, if you don't get a result, but your sample goes into, banks for researchers to look at, actually you're helping those researchers build a picture and potentially find that gene in the future. So,
absolutely. None of this would be possible without the patients who have the commitment to have their DNA analysed. And obviously there are practical reasons, because if there's a treatment, that's a very practical need. But there's also the research and making sure that we can diagnose everybody in the future. And we have to keep improving and getting better and better at doing that.
Yeah. Leading on, we've got some nice questions that lead on nicely from each other, because the next question is, are there any treatments being trialed that could work regardless of knowing the exact gene? And is there starting to be more of a balance between these and gene-specific treatments? So I think that's referring to the fact that to start with, it felt like everything that was coming through was a gene therapy. The one treatment we have on the NHS is a gene therapy, and you must have that particular gene as the cause of your condition. So, there are other things coming through now, though.
This is definitely the future, and I feel a lot of energy has gone into understanding single gene disorders causing RP and developing a possible gene therapy to restore that gene or put back its function. But in the background, it's been well recognized for a long time that that's actually a very ambitious way to do this. It's very time consuming, very expensive. Each patient is almost having a tailored therapy for their particular gene. It's almost personalized medicine. So these are the things, these gene-specific treatments, universal treatments. Sometimes they're called gene-agnostic treatments. There's a
Mhm.
lot of activity because they would be applicable to so many more people. So the types of things that are going on in the background are thinking about what's the common pathway in retinitis pigmentosa, for example, or whatever your condition is. There's going to be a big process of disease, which is like a cascade of one thing leading to another, to another, to another. But at the end of that final common pathway, your rod or your cone is going to be sick, and it will obviously be affected to its detriment. So if we could target the final common pathway, irrespective of which gene had originally gone wrong, we might be able to stop that rod or cone photoreceptor cell dying. So we're targeting this common pathway. And bear in mind, there could be something between 250 and 350 different genes that could cause retinitis pigmentosa alone, or different definitions of RP in macular dystrophies. Other ways we now want to approach this is definitely a lot of interest in neuroprotection and neurotrophic support. So putting in growth factors and neuroprotectant type of chemicals or molecules which would rescue the rods and the cones or keep them alive for longer. So that's another. Another would be if you haven't really got functional rods or cones, but you still have the retinal ganglion cells, you could put in something that will help those retinal ganglion cells to absorb light and become sensitive to light. And that's called optogenetics. And that's definitely being actively researched as a therapy now, actually. And potentially that's something that will be appearing quite soon. I think the reliance on specific gene therapies to replace or enhance will run alongside these other treatments. But these other treatments could actually prove to be, once they're out there, faster, quicker, and more widely applicable. And certainly a lot more cost effective because they'll be applicable to such a lot of different conditions. So I think it's a big area of growth and interest, and a lot of research, I think, is looking in this direction now.
Can you envisage that one day there'll be people will have the option of sort of multiple treatments or treatments, concurrent treatments. So perhaps something that targets the root cause, but then also an antioxidant therapy or
Yeah,
a
yeah.
neurotrophic therapy so that they complement each other.
Yes, it's like you want to be able to hit many different targets. So if you were able to give some protectants that are protecting nerve cells, neurons, neuroprotection, you might do that as well as the gene therapy, because you might argue that we'll give the gene back into those nerve cells or rods and cones, but the ones that were already really quite sick, they need a bit of nurturing. So we need to give them some other things as well. And I think I wouldn't really say it would be a cocktail, but I think it would be quite tailored to what that individual person's
Yeah.
condition is.
And again, leading on quite nicely, are there more treatments being developed for earlier stages of sight loss than for later stages? Is there any hope for those with very advanced disease,
Yes,
for example, who have no remaining vision or
yes.
just very little light perception?
This is the type of thing that really hits the papers and the news, and we've heard about it recently, obviously, with the sort of bionic chip implant type of situation.
Yeah.
But whenever there's any news report, they'll often report it, and you'll come across it yourselves, and you will see it on many sites, and it will causing a huge amount of interest and excitement. So the issues there, I think, are that I think there's still quite a long way to go for that to be really good vision. So if somebody has very severe or advanced disease with virtually no light perception or no light perception, obviously they're going to be really keen to get anything back. And obviously it could be anything from just light perception, but to reading letters is really what people want, or seeing some, features, outlines,
Yeah.
faces, objects. So this is happening through the possibilities of the bionic eye, which is, a retinal implant. There are those that could go under the retina, so where there are still some active retina remaining, and that's perhaps the ones we've been hearing about recently with age-related macular degeneration. There are other more ambitious things happening, which actually even bypass the eye, which send impulses from a camera directly to the visual cortex. That sounds, much more complicated, but incredibly exciting. And there is research already looking at that. And it has a huge potential. If somebody has got a optic nerve, for example, that's been cut, or has an optic nerve that just doesn't work anymore,
Hmm.
the signal can't get from the retina down the optic nerve to the brain. So that's one area. Other things that mentioned was taking the cells that are there, the ganglion cells, and making them see light and respond to it, this optogenetics. That would be a way of helping people with very severe disease. Then there is stem cell therapy, which everyone imagines is around the corner, but it does seem to be a very big corner. Basically, that's been extraordinary in one area where in age-related macular degeneration, particularly the dry form, where you have atrophy and loss of central vision, people have been growing the retinal pigment cells, the retinal pigment epithelium in sheets, and then the possibility arises for surgically popping them in, under the retina and actually restoring sight in that patch. And that's exciting and really promising. Stem cell therapies for replacing rods and cones are obviously actively researched for a number of years. They've met a lot of hurdles and overcome them, but there are still many hurdles. It does seem that would be helpful, but the biggest issues are getting them to settle in the retina, connect up, talk to other cells, and then send signals down the optic nerve. So this is quite complicated.
Yeah.
But you should never say never.
Yeah, and there's some exciting things going. I mean, Retina UK is funding a couple of projects that are looking at options for stem cells. They're obviously laboratory based. This is all early stage, but there are lots of people out there working on that as well. So
Yes, I think people have. I think we might talk about things like ways of adapting to vision through aids. So we can talk about that later. But obviously, if there is no way of restoring the function of the eye, then there are other ways a person could be given independence. But we could talk about that later.
yes. Bit of a change of subject slightly. Really good question though, because I've been getting inquiries about this at work. So this question says, I'm a 53-year-old woman and have had lots of conversations with women of a similar age about the impact of menopause or perimenopause on vision. Is there any evidence that menopause, HRT, or other hormonal changes can influence retinal health or progression of disease?
So menopause, reduction in estrogen undoubtedly does affect every aspect of your body. And I'll give you another example. In pregnancy, women often do say they actually have blurred vision also because there are rises and falls in hormones that can potentially make your lens work better, for example, in focusing or so. So there's lots of evidence that all these hormonal changes will have an effect of every part of your eye. I think the hormonal changes have been seen, but they are relatively small. So no one particular change stands out as really impacted. There's evidence that things like age-related macular degeneration is slightly more common when there's lower estrogen. And that might be why, when you're an older woman, you'll be more likely to get this than potentially an older man. I mean, there is a difference there. Same might be for glaucoma. We do actually see that similar effect in glaucoma, and people have said it could be because estrogen has a very specific neuroprotective function. Again, I spoke about things that were neuroprotective earlier, but molecules that will protect nerves, and estrogen is really powerful in that actually. Also, when you have a lower estrogen, you become more at risk of like cardiovascular problems to do with your blood vessels, your heart, and so on. So that could affect the vision, but that's not it's due to the blood supply more than anything else. Not really inherently the eye. So hormonal changes will affect all these conditions that we normally know people will have as they get older. So the big crunch comes to, does hormone replacement therapy make a big difference to these conditions? So some studies say that there's a slight effect of hormone replacement therapy on some of this, but it's very a small amount of effect. It's controversial and it's inconclusive, and it's far from certain that hormone replacement therapy at the doses that it's currently used would have a protective effect enough to make a massive difference. You have to think, if you are interested in estrogen replacement therapy or hormone replacement therapy, what are the other reasons for having it? So think of all the benefits, the pros and the cons, and vision would be potentially the tiny little bit of an extra there, but it's not a explicit indication for it. And I would be rather sort of wary of saying that we know that it makes a difference. It's
Yeah.
seen in population studies, but on an individual level, it's quite hard to know if that's really the cause of people's vision that's changing.
Yeah. So very uncertain, really, and people need to take a holistic view and sit
Yeah,
down and have a chat with the GP
yeah.
about the whole picture.
Oh, well, I just add to that though, if you've had a very early menopause, so unfortunately, some women have a menopause in their 30s or, really early due to other things, but
Yeah.
there is really strong evidence actually that that's potentially even more likely to be associated with an increased risk of things like lifetime exposure, glaucoma, AMD. So early menopause, I think, does need to perhaps be given extra emphasis.
Okay. Good point. Um, Another type of medication. So, with the increase in use of weight loss jabs,
Yeah.
I've heard that there may be a risk to sight with improper use. Is there any truth to this? And should people with inherited retinal disease avoid these jabs? So, I think Robbie Williams was in the media not very long ago, saying that he thought that his vision was affected by weight loss jabs.
I think perhaps look at it first from the perspective of somebody who doesn't have RP per se or a retinal dystrophy, but who may have other retinal problems, for example, diabetic retinopathy, macular degeneration, and so on and so on. We have one particular risk that comes out of the use of these drugs, which is perhaps standing out the most, which is a type of optic nerve stroke where there's blood supply problem to the nerve of the eye, and it's called a non-arteritic ischemic optic neuropathy. Bit of a mouthful, but
Yeah.
it is a very rare, but it's increased apparently in people who are using these types of drugs, particularly longer term and at higher doses. But the problem with this particular complication is it's very serious and it can lead to quite serious central vision loss. But it's really rare, I would emphasize.
Yeah.
The other things that people might be noticing could be, well, if you're on these drugs, then, for example, if you're diabetic and you already have very high glucose and you're getting diabetic retinopathy and you radically bring up down your blood glucose, you can actually sometimes see a worsening temporarily of the diabetic retinal problem. So you need to talk to your clinician about what you're taking. And the same has been said, apparently, in some studies with age-related macular degeneration, that very long and high doses of these medications have been said to potentially increase the risk of some people's AMD progressing, but the jury is really out on that. So overall, I think if you're taking the drug under supervision, you're making sure that you are under a doctor and you're discussing it and your concerns are listened to and you don't ignore any symptoms, that you are supervised, that you're taking the right doses at the right time, and that you're trying your best to make your diet as good as it can be, because it's not about starving yourself when you're on these drugs. They have a huge safety profile because millions of people are taking them worldwide now, and the numbers of problems are really quite small, but they're not zero. No medication is probably without some problems. So people with retinal disease like RP, the jury is even more out on that because there's very little evidence that pre-existing retinitis pigmentosa has any specific issues with these drugs. But again, rapid weight loss, poor nutrition, if you're just starving yourself or if you've got other diseases going on as well, it makes it more difficult to take this without good supervision. And I would say you should really speak to a doctor about it and seek immediate sort of attention if there's a problem, if you have any issue with the vision.
Yeah, that's really good advice. So another thing that people can very easily do without supervision is take a nutritional supplement. So this question says, I occasionally come across adverts for nutritional supplements that are specifically aimed at supporting retinal health. For someone living with an inherited retinal condition, is there any evidence that they are worth taking? Some of them are very expensive. So we do occasionally get queries at Retina UK about these as well.
Absolutely. Well, this is something that we probably discuss in every clinic with individuals who have retinal problems, particularly age-related macular degeneration. And also in clinics with inherited retinal dystrophies, because I think people do want to know if they help. So nutritional supplements shouldn't replace a good diet. They shouldn't replace really good nutrition, fruit and vegetables. They shouldn't replace the fact that you shouldn't smoke and that you shouldn't, expose yourself to any other risks. So moderate sun exposure by wearing sunglasses and all these things. They can help your general health if you're malnourished or if you're weak or frail or you really can't cook, but they're definitely not a replacement for good nutrition. So in retinitis pigmentosa, there is no evidence that the trials that were done for AMD cross over to retinitis pigmentosa. So good studies were done called AREDS 1 and AREDS 2, where it was shown that some formulated supplements might be beneficial in patients with dry AMD, as slowing down conversion to wet AMD. So there has been a specific push to suggest to some groups of patients they might be beneficial, but unfortunately they're not prescribable on the NHS, so they're expensive. The effect is limited. And there are some things you should watch out for. So if you have retinitis pigmentosa, you really shouldn't take high doses of vitamin E. That's actually been shown to be really not a good thing in retinitis pigmentosa supplementation. So if you're taking a supplement, check that it isn't a really mega dose of vitamin E. And even more importantly, don't take a mega dose of vitamin A, particularly if you have Stargardt disease or the sort of cone rod dystrophy, macular disease, because the high doses of vitamin A could be detrimental in those with Stargardt disease. So I think you need to be careful what you take, and maybe you should actually speak to your consultant ophthalmologist, physician, or somebody who is able. You could find out who's the best person to talk to. I think nutritional supplementation is appealing, but it's probably not the solution for most people. And there are lots and lots of formulations out there containing a variety of things. The two things that perhaps were the most successful in these concoctions were lutein and zeaxanthin. So in the AREDS formula, when they did the really good clinical trial, they showed some benefit to patients with age-related macular degeneration. So that might be, the best thing. And omega-3 fatty acids, the sort of fatty acids you get from fish foods. But high doses of all the other vitamins, especially if you have RP, possibly a little bit less likely to be beneficial and could be risky actually. So
yeah, it's really tricky. It's so tempting to be able to walk into a health food shop and buy something that's actually going to help. But I think the thing to remember, some of the claims that I've seen about some of these products are really quite stark and
yeah,
incredibly strong, and it's almost like they cure everything. And I think it's important to remember that all of these different conditions have different underlying mechanisms and different processes going on, and what works well for one thing may not work well for RP or another inherited condition. And our community has what are actually rare conditions, and they're less likely to be studied, or so it's definitely worth, like you say, a conversation with a professional, and just to be sure that.
I think the reason it's also important to remember that when a drug is approved for something, there's a very high bar in terms of proof, and you can't make claims like this on the internet about the drugs that
Yeah.
non-drug vitamin supplement doesn't need to go through any regulatory process, and actually there's no legal situation around what claims can be made. There's really probably no barrier to the person selling it saying what they want within reason. And I agree with you, you'd sometimes look at the claims that are made, which are astonishing. I can't understand how a vitamin supplement that's basically a multivitamin with maybe some of them have bilberry extract and some of them have other things, how it could potentially, I don't know, make your eyes less tired, or make your eyes less dry, or improve your vision from where it was before to where it is now. It seems incredible, because if that were the case, then I honestly believe that it would be used. So it's very hard to show negative results, but I think it's important to be skeptical.
Yeah. So going back to the more general picture of research in inherited retinal disease, um, this is a tricky one. I think it's very complex, but what do you think is the greatest barrier to getting more treatments for IRDs? And where do we start with that one?
I think there are two types of problems that are holding the field back. The first is the kind of the complexity of the science and the challenge associated with understanding the diseases, because there are potentially, let's say, 300 different genes for
Yeah,
RP. Just keep a simple
yeah,
number. So that's potentially 300 different proteins that can go wrong. So 300 different pathways by which a rod or a cone could become ill and die. So that is
yeah.
important because it means that one size won't fit all. And the problem of that, they sometimes it's called genetic heterogeneity. You might have heard that if you have a gene test, they'll say, well, we know lots of genes could cause this. That's why you do a test when we look at all the genes. So that's one big problem, because then obviously resources are limited, and the question around how generic treatments could work better is a brilliant one, because that would get round that. Um,
Yeah.
the other thing is patients are affected by these conditions. They are rare or ultra rare, basically very rare disease. And that means that there's fewer patients to take part in research studies. And then there are people dispersed all around. So when you want to treat somebody in a trial or test a new treatment or even roll out a treatment, it's actually sometimes quite hard to find the patients. So that's that part of it. So it's great that people are in networks or that they sign up to information newsletters and things like that, because they'll find out about this. Another might be that some of the treatments would be aimed at very early disease. To stop it progressing, you'd have to treat it early.
Hmm.
We've already said that. And then others would be suitable later on. So it's not, again, one size fits all. So that's the complexity of the disease itself. But I think, to be absolutely honest with you, I think there's an even bigger problem. If the world were a perfect world and we had an infinite amount of money, we would be able to do this. But it's extraordinarily expensive and challenging, beyond anything that you might imagine, like developing a COVID vaccine, which was relatively sort of simple, one target.
Yeah.
So the development costs, the research, and the manufacturing, and all the sort of things that people have to go through, then getting it through sort of authorities, getting it reimbursed by the NHS, and showing that it's actually effective. So they're not a total barrier. They just mean that there are, going to take longer time to get through some of these barriers. But I
Hmm.
think somebody once did a calculation that if every single gene therapy that could be approved was approved, ultimately, there'd be no healthcare system in the world, not even
That could,
America, that could
yeah, that
possibly
could.
sustain it, because it would be the GDP of a small country. And so these single cell gene therapies clearly won't serve our whole population. So
No.
it'll have to be a multifaceted approach with, as we've said already, looking at much, much more broadly applicable treatments, which will have a bigger chance of helping more people. Um, and I think people are very aware of this. So I think they're trying very hard. But I think I'm really excited about the gene therapies, because they will help those people who have these specific conditions, and will learn an awful lot about how best to treat that condition, which will then help us to treat other similar forms of RP. So we'll learn that worked really well, but what was it? Why did it work? So I think it's got its place. It's not the case that we should stop working on single gene therapies at
Hmm.
all, but we have to not put all our eggs in one basket.
Hmm. It's all these different pieces of the jigsaw, isn't it? There are so many different pieces of the jigsaw to put together, like you say, and it's just really, really complex. Um, to your point about as well these conditions being rare and finding people, what I suppose what would help as well is data and knowing
Yes.
where people are and people being prepared to take part in research or share their data into a repository at Retina UK. We're quite keen to move towards a registry, which of course you know, Marcela, because you're helping us with that. But we don't know if we can do that at the moment because it's a big project. But if we knew where everybody was, and as long as they were happy to be part of that registry, if we knew where they were and we had some data about them, about their clinical situation, then that would obviously be one step that would perhaps help a little bit.
Yes, I think, I mean, there are natural barriers too, because I've been thinking a little bit about this in the context of talking to my patients. People who have a blinding condition like RP or a macular dystrophy, they're not automatically going to want a treatment at any cost, at any
Hmm.
price to themselves, or at any risk. There
Hmm.
is a sort of cutoff between what you might be willing to risk to have a treatment that could potentially cure you versus the fact that it could be highly risky. So patients are very aware that there is a potential sort of trade off, really. They won't want a therapy that's highly risky, even if it has amazing possibilities. They'd rather, I think, on the whole, make that judgment on a case by case basis, but they need to know what are the risks of the treatment and what is its likelihood of success. And I think it's wrong, perhaps, to develop treatments that patients don't necessarily want because they might
Hmm.
think them they're too dangerous or too risky. So I think it's quite important at this stage to ask patients as a whole, I'm talking now really, not just
Yeah.
individually, how they view that, where they feel their priorities would lie. And that might help to direct the types of treatments that are developed. And that's quite a big project, really, to get that type of um, community conversation going as well and talk to patients about what they feel they would benefit from most.
Hmm. Yeah, that's really interesting and really worthwhile doing, actually, something for us to think about perhaps.
Yes.
Um, the last question we've got in advance was, how do you think advances in technology are helping researchers in the lab, as well as people living with inherited retinal disease as assistive tech, which you touched on earlier as well?
Yes. I think, well, we can go to the assistive tech first. I mean, certainly the type of retinal implants and chips and that sort of thing. Secondly, and I've seen this myself recently, and I'm becoming a bit of a convert. I've seen the most incredible glasses and assistive sort of technology built into glasses and devices and wearable cameras. Um, I was blown away by patients telling me about it recently, quite spontaneously, and demonstrating to me how it actually worked. It was just unbelievable. So I felt that particular individual sitting there telling me was totally transformed by it, actually. And I couldn't believe how they had changed from last year to this year, how their confidence had grown, and how they had actually started to be much more independent again. So that sort of technology is going to continue to improve and become more accessible. And it's not for everyone, obviously. Um, Other tech that's really helping people in screen readers and magnification and these sort of scanners that then read out to you, which are portable. So you don't have to
Yeah.
necessarily wear them as glasses. Um, and navigation devices, which is all basically led by, laptops, phones, computers, tablets. That digital revolution, I think, is changing things a lot. So there's much more, I'm sure, that can be done. I'm not an expert in that field, but that's really important. In the lab, I think there are two main things. We've touched on genetics and the complexity of analyzing somebody's genes. That's getting better and better because of AI, machine learning, and also this kind of thing called bioinformatics, where we can analyze
Yeah.
large amounts of data, which no one person, not even one computer, could do. So it's going to improve diagnosis, and so on. That'll be amazing. So sequencing of DNA and then analyzing the results. The other thing that's really helping is analyzing images. So again, this is where tech comes in. So you go to have a scan when you go to the optometrist or the hospital. You have a particular condition, and if AI can be used to help interpret it rapidly, accurately, there's an awful lot that could be done to improve diagnosis and management. So I think those are really important areas of tech that are definitely going to impact on the way people can actually be treated.
Mm. And genetic diagnosis as well could be, so we know that there's a team, i2gene team at
Yes,
UCL,
yes,
who are working on that. I just think that's so clever that AI can look at retinal scans and have a really good stab at
yeah,
working out what the genetic diagnosis is, and they've managed to get that really, really quite accurate over
yes.
just a small number of relatively small number of genes at the moment, but imagine just being able to go to one appointment and have a series of scans and then find out almost straight away.
Yes,
Um,
yes, yeah.
well,
Oh, absolutely. I mean, it's absolutely wonderful because I feel that this area of work, retinal dystrophies, macular dystrophies, was really making slow progress, but now it's really accelerated. And of course, it always takes longer than you might hope, but sometimes miracles almost seem to happen. And, change can be quite rapid sometimes.
mhm.
There's like a sort of flipping point, isn't there? So
Yeah.
I'm really excited about these things.
Um, that's great. Can we we've had a question come in the Q&A box, which is a good one because we get questions about cataract surgery quite a lot, and that's quite a difficult thing for some people to make a decision about. So this
Yeah.
person particularly has asked, are there certain procedures that can trigger or worsen cone dystrophy? So this is specifically asking about that. For example, cataract or YAG laser following cataract.
Well, if the evidence were really good on this, then I think that we would probably be able to put it in that information pack that we try to give to people. But the reason you're asking the question is probably because the evidence is not very robust or very good on this. There's possibly anxiety about cataract surgery in anybody who has advanced retinal disease, possibly because there's the thinning of the retina, making it more vulnerable to the sorts of changes that take place during an operation. And whilst we're not suggesting that you're more likely to get a detached retina, a very thin retina could certainly not have as much robustness to respond to, the pressure changes, the actual operation itself, the very small amount of possible inflammation that takes place after an operation, all these things. So we're always very wary if somebody has a retinal dystrophy to suggest that before having a cataract operation, you need to be sure that you really feel it's going to make a difference, because obviously you don't want to take a risk with the vision you have in order to not really improve it at all. And that risk rate is a very difficult thing to evaluate. So cataract surgery generally, however, is extremely safe. I don't want to suggest that it's not. It's an amazingly quick and safe operation. So if you are a patient with retinal dystrophy or any other retinal pathology, you should be making sure that the surgeon is aware of it, that they take extra measures, that they potentially give you additional drops before the operation, during and after, that they monitor you closely, and that they consider all the potential benefits or pros and cons, and that you discuss that, and that you're consenting to having it, with a sort of, hopefully with good information. But people don't have accurate figures on, is it 1 times, 2 times, 20 times more likely to be a problem. The same for YAG laser. In essence, there's no real evidence to say we shouldn't be doing YAG laser in people who've had a cataract operation, and then they need to have the laser of the little capsule, a membrane. And
Yeah.
we do it actually. But again, we don't sort of do it gung-ho. We take it quite seriously, because I feel we want to minimize the amount of laser time exposure for the very, very smallest amount of power, just to make sure that we're not in any way going to upset the retina. But if there was really, really robust data on this, then I think it would help us all. To be honest, somebody should really do that kind of
Do the
studies.
work. Yeah.
Yes. So, and in a way, I think you have to take a pragmatic view. If you have a cataract, and if the cataract is genuinely contributing to your vision loss, and you then really don't have anywhere else to go, that then tips the balance of risks and benefits. And maybe it is time to have that cataract operation. And similarly, you've had a cataract operation, it was great. And now the little membrane is thickened and it's gone bad again, and you really can't read those letters again. But you had really good result. Then
Yeah.
the time comes when you probably really should have that laser, but making sure it's done in a sensible, sensitive way. And I think most patients have experienced somebody else who's had it, and it's been an amazing result. It's been great. It's been successful. So sometimes we forget that very rarely there are problems, but it's very rare.
And I think just have the confidence to have that conversation with your clinician and ask the questions, and
Yes.
and and don't sort of let any I know in the past we've heard from people who have been told they have a cataract. They've got RP, for example. They've been told they've got a cataract, but actually it's not worth doing anything with because you've got RP anyway. And I think don't let that don't
Don't
just
let,
take that
yes.
as read. You know, if you want to explore it, then you should be able to explore the options.
There are
And
some really good examples where it's worthwhile. So, a young man who has X-linked RP
mm,
in his, say, early 40s, that's a typical scenario for him having a cataract called a posterior subcapsular cataract, which will have a real impact on central vision, glare, and reading, that sort of central acuity. That cataract, if it's removed at that stage of their life, can make a massive difference. Um, and that's a really classic example of where, yes, surgery definitely helps. I've seen such a lot of young gentlemen and older gentlemen who've had it done and said, yeah, it was amazing. Unfortunately, the retinitis pigmentosa will continue to go
yeah,
on slowly, but it's definitely worth having a cataract operation if that's the sort of
that's
situation.
right.
Yeah, yeah, if it's right
Yeah.
for you. Yeah.
Yeah. We do actually have in our resource stack on our website and on YouTube. We do actually have a podcast, I think it was, rather than a webinar, specifically about cataract surgery with a couple of ophthalmic surgeons. So if anybody's interested, look through our YouTube channel. If you search that for cataracts, I'm sure you'll find that and have a listen in a bit more detail about the pros and cons and what you can do. So, if we don't have any more questions, I don't think we do because the question box has been quiet for quite a while. Even though it's not quite 8 o'clock, I will start to close things down. If you want to uh, quickly type a question in there, then do please feel free to go ahead. But in the meantime, Marcela, thank you so much. I think it's been a really,
Pleasure.
really really good session. We've had some really excellent questions and we've talked around all sorts of interesting topics. So thank you so much. And thank you to everybody who sent in questions. And thank you to all of you who've joined us this evening. Retina UK holds a webinar most months. So this is obviously our last one for 2025, but we already are thinking about our plans for 2026 and details will be on our website very soon. Please remember that we're a registered charity. We receive no government funding and rely on our wonderful supporters to raise the funds we need to provide vital services and invest in medical research. So if you can consider supporting us in our 50th anniversary year, which we're in at the moment, you can make a one-off donation or become a regular giver. We also have our very own Retina UK lottery, where you could be in with a chance of winning £25,000 every single week for as little as £1 a line. So you could start 2026 with a real bang and support us at the same time. We have lots of really exciting challenge event opportunities next year, some new ones that our fundraising team have put together. So if you'd like to find out more about those, if you're feeling adventurous, or you just want to do a run or a bake sale or something for us, please get in touch. You can visit our website, visit the fundraising area of our website. You can email my colleagues in the fundraising team via fundraising@retinauk.org.uk, or you can call them if that's easier on 01280 815 900. We'll be sending out an email in the next couple of days, which has details of where you can rewatch or listen to tonight's webinar and details of how you can book on to our future events as well. We'll also be asking for your feedback on this webinar. We really appreciate feedback. It helps us to improve what we do and do more of what you enjoy. Thank you all again, especially Marcela, and we hope you all have a very peaceful festive season. Goodbye.